So welcome. Thank you for joining us. And it's my pleasure to introduce our presenter today. Farinah Kadir has worked in mental health as a psychiatric nurse since 2005 and is very focused through the fellowship on bridging gaps in care for our clients with concurrent disorders. So I'd like you to welcome her today.
I'd like to start, first of all, by thanking everyone for coming. I know what the workload on the floors look like, so the fact that you came to spend this hour with me, I really appreciate. Originally, I had a broader title to my presentation, but I went down the same rabbit hole that Lewis Carroll probably went down when he wrote Alice. And there was just too much information, so I've decided to narrow my focus down to ketamine and psilocybin instead, and also just look at depression and alcohol use disorder instead of the broader range of mental health illnesses. Before I get started, I'd like to respectfully acknowledge that I'm a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. It's my hope that through the work that I do, that I might be able to be an ally in helping to restore the culture and traditions of the Coast Salish people. I am an employee of Vancouver Coastal Health, but I'm not affiliated with any of the programs that we'll be discussing today. And I'm hoping that by the time you leave today, that you will have more knowledge of the history of ketamine and psilocybin use, that you will have a better understanding of the mechanism of action of ketamine and psilocybin, and we'll get the opportunity to review some of the research that's currently available and look at some programs that are also currently running. So this is me at my workplace. I work at the Access and Assessment Center, which is located at the Seagull Family Health Center at Vancouver General Hospital. It is a not so urgent mental health center. If anyone has questions about the Access and Assessment Center, I'm happy to answer those after I'm done today. So my work at the Access and Assessment Center is working with clients that often are coming in crisis, and some who have been engaged within the mental health system for many, many years. And one of the disheartening things is that many of them come in, they've been having treatment for many, many years. They've tried many medications, they've tried different kinds of therapies, but they're coming in saying that while maybe their depression has improved, they're still not feeling like they're getting joy out of life. They're not enjoying life. They're going through the motions. They're not thinking about ending their life, but that's kind of where it ends. And my hope is that our clients would have a better quality of life. So that's kind of where my interest came in. And also because psychedelic use has been in the media more, we do have a lot more clients coming in asking questions about what our thoughts are, asking for opinions, asking what programs are available. So I feel like as a nurse, it's kind of my job to know what that information is. So even though it's not a service that we provide at the Access and Assessment Center, that it's something that I'm able to help clients access. Sorry, Amir, I forgot. I was supposed to mention, I will be pausing during my presentation if there are any overhead announcements. And also, I don't know if the people in the back will be able to hear me throughout the whole, but if at some point I start to fade out, just wave and I will talk louder. Okay, so in order to understand kind of where we're going, I think it's important to look at where we're at right now. So according to the Center for Addiction and Mental Health, people that have mental illness are twice as likely to have a substance use disorder when compared to the general population. And at least 20% of people with a mental illness have co-occurring substance use disorder. And people that are diagnosed with schizophrenia, that number can be as high as 50%. And if the patient aspect is not interesting to you, then perhaps the financial will be. When we're looking at the economic cost annually for all of Canada, the cost of mental illness in Canada is estimated at over 50 billion per year, while the annual economic cost of substance use is estimated at nearly 40 billion. So while there may be some overlap in those two numbers, if you're looking at it combined, you're looking at $90 billion. And if you also look at the amount of money that gets put into those two illnesses and those diagnoses, those numbers don't match up. If we're looking at psychedelics, we're essentially looking at three factors. So there are substances that create perceptual disturbances. They can change one's subjective experiences, and they can also transform one's relation experience with their environment. One of the psychiatrists that I worked with for this presentation, Dr. Tam, he divided psychedelics based into the mechanism of action. So today I'm going to be focusing on the indolamines and the dissociative NMDA agonists. But I just wanted to leave those two other categories on there so that you can see that there are other categories. So when we're looking at the indolamines, these are your classic psychedelics, and the NMDAs are the dissociative agents. In the 1950s, phencyclidine, also known as PCP, was created and used briefly for anesthesia. Unfortunately, as clients were coming out of the emergence process, there was a high risk that they were going to experience delirium and psychosis. So towards the 1960s, PCP was discontinued from medical practice and restricted to veterinary practice, which it still is used for. And unfortunately, the downside of that, because we are creatures that like things that we're not allowed to have, it also entered into the illicit drug market at that point in time. In the 1970s, President Nixon's war on drugs led to the creation of the Controlled Substances Act. Most of the illicit substances were categorized as Schedule I drugs, which meant that they were considered to have no medicinal use and there was a high potential for abuse. Because they wanted to create something that they would be able to use for anesthesia with less risk of side effects, then the pharmaceutical company built a new substance, which was ketamine, and ketamine has 1/10 the potency of PCP, and because of that, it escaped being categorized as a Schedule I drug and was categorized as a Schedule III. When we look at the effects of ketamine on the brain, it is an NMDA receptor agonist. And I spent a lot of time learning about these neurotransmitters, so I'm going to tell you about them. So typically when we use ketamine for anesthesia, it blocks the excitatory effects of the glutamate. But when we use them at sub-anesthetic doses, because there's a downstream effect, what happens is that it creates an increase in the glutamate, and then there's a stimulation of the AMPA receptors, which causes a paradoxical effect than when you're using ketamine for anesthesia purposes. Which leads to our purposes in using the ketamine, which is to enhance the connectivity and elasticity of the brain. If we look at the evolution of psilocybin, it was used prior to pharmaceutical purposes with indigenous groups that were residing in Mexico, and it was used for medicinal and spiritual purposes. In the 1950s, after observing these medicinal and spiritual effects, it was identified as a psychoactive compound, and then we do what we normally do. We steal things and we make them ours. So it was synthesized and then it was marketed as psilocybin. It was used in the 1960s for research looking at its effects in inducing psychosis and also the therapeutic potential. Unfortunately, it was also a victim of the war on drugs, and it was classified as a Schedule I drug. And then more recently, in the I guess the 1990s are not recent anymore, but more closer to our time here, in the 1990s, there was a revival in its use for research. Okay, this is a very complex slide, and I put it in there because essentially what I wanted to just illustrate is that with many medications that are used in mental health. We're not exactly sure how it works. We have some guesses on how it works based on the symptomology, based on the effects, looking at the brain. With psilocybin specifically, it shows a response on multiple different receptors. So this is a list of all the different sites that it's creating a reaction at. But most importantly to our talk today, it does have an effect on the serotonin receptors, and that for our clients means that there's an improvement in their mood and in anxiety. So if we're looking at the evidence for the use of ketamine and psilocybin in alcohol use disorder, the very first study that occurred was in 1997, and they looked at ketamine psychedelic therapy for the treatment of alcohol use disorder. There were 3 doses that were administered at 2.5 milligrams per milligram IM of ketamine, and it was combined with psychodynamic psychotherapy. That's a fancy way of saying the psychodynamic psychotherapy is looking at your experiences in the past and seeing how they affect your reactions and behaviors currently. So out of that study, 66% of the patients were able to achieve abstinence for over 12 months, compared to 24% of patients who were in the control group. And in the control group, they were primarily only receiving psychodynamic psychotherapy. That wasn't the alcohol use disorder what was being studied, but outside of that, in the interviews that the researchers did, they also found that there was an improved presentation for challenging personality traits. There were better attitudes that clients had towards themselves. They had an improved sense of self and sense of worth, and they also found more meaning in their interpersonal relationships as well. Moving forward to 2019, researchers were then using single infusions of ketamine at 0.71 milligrams per kilogram, and combining that with motivational enhancement therapy, which uses motivational enhancement therapy uses a combination of assessment, goal setting, and MI to help clients move from their ambivalence into being change ready. The patients from this study showed an increased likelihood of being able to remain abstinent. There was a delay in the amount of time that it took before they had a relapse, and it also reduced the amount of heavy alcohol use that they were having. And then just last year, there was a study using 2 doses of psilocybin. The first dose was administered at 25 milligrams per 70 kilograms, and then the second dose was administered, which ranged between 25 to 40 milligrams per 70 kilograms. This was combined over the course of 12 weeks with psychotherapy, with patients that had a diagnosis of alcohol use disorder. And at the 32-week point, they found that clients that were receiving psilocybin had fewer episodes of heavy drinking and were able to maintain longer periods of abstinence. If we're looking at some of the evidence at depression, in 2021, there was a randomized controlled study that compared the outcomes of psilocybin versus escitalopram, which is one of the first-line antidepressants. One cohort was provided with 2 doses of 25 milligrams of psilocybin 3 weeks apart. And then over the course of 6 weeks, they were given a daily placebo. In the second cohort, they were provided with 2 doses of 1 milligram psilocybin 3 weeks apart. Plus for 6 weeks, they also received daily escitalopram doses. And both of the cohorts were also receiving psychotherapy. So the primary measurement that was used was the QID score between the cohorts, but the group that was taking the psilocybin group reported that they had less side effects compared to the group that was taking the escitalopram, and they did score better in other scales that were used to measure depression and anxiety. It's very hard to find research that is looking at concurrent disorders, but the study that was done in 2022 shows that in a trial of 3 weekly ketamine infusions of 0.8 milligrams per kilogram IV, when it was combined with psychotherapy, showed a significant increase in the number of days not using alcohol, and a decrease in the Beck's depression inventory. When we're looking at the treatments that are available, I've divided them kind of into 3 categories. So we're going to talk about first programs that are covered by our provincial health service, that are government kind of run, if you will. There is also an organization that is a nonprofit organization that provides services, and then we'll also be looking at treatment through a private clinic as well. So the UBC inpatient ketamine treatment program is an inpatient program, and then the ketamine intervention program is an outpatient program. They're both run through UBC, and then the outpatient program also does have an arm that runs out of the hospital in Squamish. The inclusion and exclusion criteria for both programs are the same, so I'm just going to go over them together. You need to be over 18 years old. You have to have a diagnosis of either depression or bipolar. And this is not like, the use of ketamine is not like first line treatment. You have to be able to show that you've tried other treatments in the past and that they have not been successful, and not just using medication, but also using either therapy or possibly even ECT as well. And Dr. Tam also asked us to emphasize that ketamine is not to be considered solely as an antidepressant. It's to be used as an augmentation to existing therapies. So if a client is coming in saying that they want to get off all of their medications, they just want to do ketamine and then be off on their way, that's not really the way that this particular program is working. For exclusionary criteria, because of the effects of ketamine on the brain and the kind of uncertainty in terms of what the exact mechanism is, clients that are actively psychotic are excluded from the study. If there's any recent substance use within the past 6 months or any history of ketamine abuse, they're excluded. Dementia, delirium, any significant personality disorders, clients that are pregnant or breastfeeding, any previous contraindication to the use of ketamine or any related compounds, and then the listed unstable medical conditions. With the medical conditions, it's not a hard no that if you have a diagnosis of any of these, that you 100% will be excluded from the programs, but it will require a deeper conversation to see whether it would be safe for you to continue on. The treatment is administered over the course of 3 weeks, and clients are starting out at a dose of 0.25 milligrams per kilogram. They receive that dose for treatment 1 and treatment 2. During the course of the treatment, when they're receiving the ketamine, they also get an hour with the psychiatrist that's administering and running the ketamine program. Following that first week, if there's an improvement in their presentation, then they remain at the same dose and they receive that dose for weeks 3 and 4. However, if there isn't an improvement, then there is an increase in the dose from 0.25 to 0.5 milligrams per kilogram. And then in the last week, same thing happens. If there is not an improvement, then the dose increases to 0.75 milligrams per kilogram. Otherwise, it stays at the dose that was already working for the client. This program only runs for the course of the 3 weeks, and the clients are limited to the maximum of the 6 treatments. In terms of measuring the success, because this is a new program and there is a lot of statistics and research being kind of worked around the program, there are a lot of different measuring tools that are being used with the clients. So the MADRS is the Montgomery-Åsberg Depression Scale. There's the Quick Inventory of Depressive Symptoms and Self-Report, the General Anxiety Disorder Scale, the Columbia Suicide Severity Rating Scale, and then the Clinician Administered Dissociative State Scale, and then vital signs as well. One of the things that is just to get a better sense of what the psychedelic experience is, that is what's being measured in the dissociative state scale. A lot of clients assume that they're going to have a dissociative state, but at the doses that are being given here, that's not necessarily the experience that the client is going to have. So it's just something to tell clients about prior to that they may not experience that, so that they're not feeling disappointed if that's not what happens when they're receiving their treatment. So as I mentioned, it's a maximum of 6 treatments, which clients receive twice a week for 3 weeks. In the inpatient stream, their vital signs are measured every 15 minutes for an hour, and then they return to the unit. And then at the 2-hour and 4-hour mark, their staff on the unit will be measuring their vital signs. The staff that are working in the lounge are nurses that are trained in ACLS, the anesthetist, and the physician that's administering the treatment. One of the big factors that can really make a difference in the administration of the treatment is how comfortable and how safe the client feels. So this is really kind of client dependent, and they're given a lot of options for maintaining their comfort and for maintaining their safety, and then it looks like whatever is right for them. So there are lounge chairs that are available. If they choose to have blinders, they can have them. If that makes them not feel okay, then that's okay too. If they want to have their headphones on and block out external stimulation, they can do that. And if they want to be involved and kind of more involved with what the clinical staff are doing, then they're allowed to kind of partake in that as well. These are some considerations for the outpatient treatment. So with the outpatient treatment, clients, obviously, as the name indicates, are going home. But their time in the clinic is 2 hours opposed to the 1 hour that they spend if they're already inpatient. There are restrictions. So if your client is working or if they're responsible for childcare, they're going to school, there's obligations in their life, they need to be aware that for 24 hours after their treatment, it's expected that that someone's going to be taking care of that for them, because they may not be able to. Their vital signs are monitored for the first 100 minutes after their treatment, and assuming that everything is they're at their baseline, then they're discharged from the clinic for that day. With the outpatient treatment, there is maintenance treatments that may be offered for up to 6 months following their initial first 6 treatments. Their referrals for the outpatient treatment program should be coming from the community, from physicians or from psychiatrists, or they could also be coming from other therapists. But the expectation is that the client will be maintaining their relationship with that therapist, and that they don't get the same connection with the psychiatrist that's going to be doing the inpatient therapy. So they're expected to follow up with their existing provider in the community. Roots to Thrive is a nonprofit organization that provides ketamine and psilocybin therapy. Their inclusion criteria is a bit broader. They don't go into a lot of the same specifics as the VCH programs. So they expand their diagnosis to also include PTSD, substance use disorder, anxiety, and they do have a psilocybin group for clients that are diagnosed with terminal illness with limited life expectancy. They can be using substances, but they need to be stable enough that they're going to be able to participate in the work that's expected from them within the group. They need to have the time away from their personal responsibilities, and some of the pre and post sessions are completed as virtual sessions, so they need to have access to reliable internet. For the ketamine leg, the exclusion criteria looks at emotional instability. This is kind of where a lot of the personality disorders tend to get taken out of the running for the programs, if they've got any active psychotic symptoms, and then any medical complications, including pregnancy, delirium, dementia, and then any vascular disorders or hypertension. For psilocybin, there's fewer exclusion criteria, so pregnancy or lactation, and the main medical conditions that are barriers are poorly controlled diabetes and hypertension. There's the ketamine program is offered with two options. One is offered as a group-based program or individual. In the individual program, there's 3 phases. In the preparation phase, the clients receive 3 60-minute virtual sessions with their therapist. In treatment, they receive 3 to 6 4-hour ketamine-assisted therapy sessions. In those sessions, there's a therapist and a nurse present. And then following their ketamine-assisted therapy session, they receive an integration session where they are given the opportunity to process things that may have come up when they had their ketamine-assisted therapy session. And this can be 4 1-hour integrated sessions. In the group-based program, it's 12 weeks of community practice meetings. There are 2 professionals, and I'm going to go over who the professionals are. That's a very loose term, that are employed by this program that participate in the group-based program. And then they receive 3 ketamine-assisted sessions that they do together as a group. And in that group session, they're expected to obviously participate in person, so they need to be able to physically attend the location. And then following their ketamine-assisted session, there's an integration and education sessions. For treatment-resistant depression, the individual or group-based program for psilocybin is divided into 3 phases as well. So in the preparation phase, there's the virtual sessions. In the psilocybin session is just 1 single treatment, but it's an 8-hour session. And then following that session, there's 1 integration session available. The group-based program is specifically for clients that are diagnosed with end-of-life distress or depression related to their terminal diagnosis. It's 8 to 10 weeks of virtual practice. They are supported by 2 professionals as well. There is 1 psilocybin-assisted therapy session within the group format, and then the integration and education sessions as previous with the other group. The staff that are hired are physicians, nurses, counselors, and somatic practitioners. The somatic practitioners is the category that they use for any of the clinicians that practice any sort of energy healing. So some of them do Pilates, some of them do energy healing, Reiki, those kinds of things, yoga. There's a broad range of different categories that fit under that somatic practitioner category. This is where you'll notice the biggest difference. So for ketamine, and this is a nonprofit organization, so all they're doing is covering their costs. They're not making a profit. So for ketamine, the individual program can range between $7,500 and $10,000. That range is dependent on how many ketamine sessions you're actually getting. So that range was 3 to 6. And then if you're doing the group-based program, it's $5,850. The psilocybin is discounted. So for individual programs, it's $2,300, and for group-based programs, it's $2,800. I don't know what kind of clients you guys work with, but most of my clients can't afford this. And then lastly, this is Ethiomed. It is a ketamine-assisted therapy and pain clinic that's located in the interior. I'm only going to be talking about the ketamine-assisted therapy, not about the pain component. So their inclusion criteria is very, very brief. All you need is a referral from either a physician, a psychiatrist, or a pain specialist. Their criteria is that you have a diagnosis of depression, anxiety, a mood disorder, or PTSD. The only exclusion criteria they have is that you have, if you've got a history of schizophrenia, alcohol use disorder, or any other addiction. And they don't see anyone under the age of 19. They do list on their website a variety of different health problems, but they provide the caveat that if you call and speak with their clinicians, that they will see if there's some workaround that they can find, or if they can help you stabilize the medical conditions prior to engaging in therapy at their clinic. It's going to come at a cost. Yes.
So this program is really only helping folks who have like depression and anxiety, right? It's not dealing with concurrent disorders.
No.
Okay, thanks.
Yeah. So when we're looking at the cost of this program, there's an assessment fee of $399. That's just to assess whether you meet the eligibility criteria for the program. And then if you are approved for the program, each individual ketamine experience is $1,300 per session. But wait, there's more. It comes with, it does come with a pre and post counseling session. And they do have a new online platform called Odyssey, which provides guided breath work, meditation, yoga, and grounding techniques, that kind of thing. So when we're looking at where things are at right now, just in terms of the clients that we're working with, there's a high prevalence of clients that are struggling with mental health and substance use concerns. We've looked at the cost of that it's costing the entire country in terms of treating and diagnosing and helping clients, but also that there's a growing trend for more and more clients that are not receiving adequate treatment from the existing treatments, and a lot more exploration going into the use of psychedelic treatments. And especially if you're looking at the treatments if you're using a psychedelic, it's a very measured period of time. So it's not this lifetime commitment to always being on medication and switching back and forth. It's not having to go to therapy for many, many years. The idea is that it is looking at a shorter treatment. Sorry, there's a question back there.
Yeah, I was just gonna ask for the psilocybin and therapy. If people are already on an antidepressant, is the goal of the psilocybin therapy to transition someone off of an antidepressant so that they don't need to take medication every day, or would they stay on their antidepressant and this would be sort of an supplementary in the same way that the ketamine program is?
Yeah. So I only looked at that format where it's being used as an in an augmentative fashion rather than as a replacement. So the idea is for the psilocybin to help in the therapy session to allow space and freedom for clients to be able to kind of work through whatever's kind of led them to where they're at that point. There is a lot of clients that come in talk about microdosing, and when we're looking at microdosing psilocybin, then that's kind of more the effect that clients are potentially looking at is using it as an antidepressant. But there's not really a lot of research that's in support of that, especially because a lot of clients are logging into YouTube and learning from Joe Schmo, who's in his mom's basement teaching the world about how to use a psychedelic substance, which is hard to, no disrespect to Joe Schmo, he might know what he's talking about. But in terms of the research that goes behind that and the measurement and the technicality of that information, it's hard to present that in like the medicine field and ask for funding based on that information that's provided in that way. And then so this kind of comes back to where I started as a nurse. My hope is that as we see the positive effect that clients are receiving from the use of psychedelics, that we're able to support not only research, but also helping clients to be able to have better access to the treatment programs. I think not even if you work outside of mental health, I think that people come across people in their daily lives as clients, as friends, as colleagues that have tried different antidepressants, that have been going to therapy for many, many years and still feeling like something's not working. So I think this is another avenue to explore that might be able to give clients and our loved ones and ourselves a better option in terms of treatment. Yes.
Can somebody access this if they're
So the ketamine program that's offered through UBC, that is the only program that I'm aware of at this point in time that is accessible by people that, like, anyone that's got access to provincial healthcare has access to those two treatments. That's the only one that I'm aware of, the outpatient and inpatient students of those. I appreciate the questions and I hope there's more coming. I did want to acknowledge and thank the people listed here for walking me through this process, for answering my questions, for explaining to me the complexities of how our brain works, and also just for helping me stay focused and maintain my sanity. My slides will be available if anyone wants access to them, and my references are available on there. If anyone has any questions for me, this is my email address and where you can find me. And I would love feedback on how effective and how useful this information was. So please fill out the survey.
And we do have time for some questions. So yeah, I just want to invite folks in the audience, both here, and then also we've got some questions in the chat as well. Oh, okay, great. All right, so maybe we'll take some questions from the audience.
So I'm just wondering, because when they're saying like excluding people with personality disorders and then also being able to treat people with mood disorders, often as we know, sometimes there's overlaps in those categories.
Yeah.
And I know it's not like a perfect science, a little bit more than art in terms of sort of having an individual assessment of each person.
Yeah.
But I guess they weigh sort of maybe where study might stand. Somebody maybe might have some personality disorder, maybe not fully diagnosed, and then clearly experiencing mood disorder or mood instability. There's still potential for that person.
Yes. Yes.
Based on.
From what I could see and from the conversations that I've had with the psychiatrists that provide the services, they will consider it if it's not their primary diagnosis. Like if there's a significant mood disorder, then that would be the priority. And then as long as there's some way to kind of work through the personality elements, so it might mean that they might need to do a bit more prep work before they get included, but it's not a hard no for that.
Great. Are there any other questions from the audience?
Is that great cookies?
Yes.
Two questions. Your placement, it was it, what age population were you serving or supporting?
Sorry, through where?
Were your addictions placement or where you work?
Oh, at at the Access and Assessment Center, yeah.
At AAC.
Yes.
Okay. And I thought there might be a youth component.
We're 17 and up.
Yeah, okay.
Yeah.
So.
But we do see younger in a crisis.
Okay. Maybe because I don't know much about this. This seems like too good to be true. So like, what are your thoughts about these as treatment options?
The way that it was explained to me in its simple, like completely simplest form, is that a lot of times when clients go into therapy, there's so many things that mentally block them from being able to fully partake in their therapy sessions. Previous traumas, fear about what this person is going to think about them. And from what I could see, the experience that clients report is that when they use the ketamine or the psilocybin, it removes that anxiety and allows them to fully partake in their therapy session. And that might be what they're getting their benefit from. So from my reading and from my experiences, that's kind of where I'm seeing the benefit of it on a very practical level. Yep. So if you go to they're called Roots to Thrive. If you go to their website, there's actually a list of the research programs that they're currently committed to. And they are nonprofit, so they do take donations and they do take funding from private sources. Yeah, no problem.
And then we've got a question from the chat here. So considering equity, do you have any concerns that we might be inflating the efficacy of this treatment when our patients already have difficulty accessing many forms of therapy in the majority of cases?
Oh. That's complicated. I think that's where knowing more about the treatments and their efficacy can help us advocate for there being better equity to have more clients access it. Because if we really think about it, the clients that we work with that are probably most disadvantaged, that have the long history of generational trauma, that have histories of PTSD, have history of sexual abuse, all kinds of other abuse happening. Those are our most disadvantaged clients and the ones that are falling through the cracks. So to me, I don't think that it's bad to bring light to this, although there's limitations for it, because I think that if we can make a good case for it, it can be more readily available to more people, especially the ketamine, because the ketamine it's a formulation that's already available. So in terms of cost, it's not really outside of anything that's already being provided.
I have a question about one of the downsides.
Mhm.
There are reports of like patients who are in treatment under like associated like sexually abused or taken advantage of. They don't know like the center effect that's happening. Like what was your experience finding? Like did you read much about that? And like are there centers out there that are maybe less regulated where like there's less things happening to the centers?
Yeah. So it wasn't something that I looked into or that I researched, but I will say just in terms of accessibility, it's not difficult to become a therapist that has licensing to provide this therapy. And it, like when I first started working on this, I just did a broad search of psilocybin and ketamine availability with therapists. And the list is huge. And I don't know what the regulation is for all of those therapists. The programs that I provided just had a bit more structure, and the nonprofit and the VCH programs are audited. Yeah, those substances are used illicitly for those purposes. So there's nothing to say that it can be used by the wrong person therapeutically in that way as well.
Right. We have one more question in the chat here. For those individuals that these therapies worked for, what sort of duration of time did they experience improvement in their symptoms?
For clients that were using it for alcohol use disorder, in the studies, the longest that they were followed was for 12 months, I believe, in the research that I looked at. And it's relatively new for clients that are. The research is relatively new for clients that are being treated for mental illness. So there wasn't really a lot of studies that looked at the long-term effects.
All right. Any other questions? One more.
If there's people on the chat.
There's some discussion and comments on there. Yeah.
Can I address that one?
Yeah.
Because so one of the comments that's in the Zoom chat is just addressing that for outpatient programs, clients need to be able to access therapy. And this is definitely a barrier for clients being able to access the outpatient program, is that it is near impossible to get a therapist that's going to be willing to see you over the long run right now. So not only is it difficult to get into the programs, but it's also difficult to find therapists that are accepting clients at this point. Sorry, I forgot to mention with the nonprofit organization, their current wait list is 800. Yeah.
Wow.
Even with the cost that's listed as the nonprofit, they've still got a very lengthy wait list. 800 people. Yeah. Yes.
Is this related to ayahuasca?
Yeah. So there's a lot of different psychedelics that are being researched. There is just so much information. So I chose psilocybin and ketamine because they're the ones that clients mention to me most when they come in at the Access and Assessment Center. So I wanted to be able to address those questions when clients come in. Ayahuasca doesn't get asked about as frequently.
And so Gabor Mate may have written about this as well, or have you? I haven't read much, but I think he's commented on that there's alternate therapies that might be helpful.
I am not familiar with his stance on it.
Thanks.
That's okay.
Just to point out clarity then, so the alcohol and drug outpatient clinics that people can access through like, Provincial, Tender, like you're saying, all of those are at full capacity, not taking anybody out. So if you go to like a health unit, sometimes you can access alcohol or outpatient, there's some health units. So even those ones that you could, for example, the first somebody's one of those that they follow you through.
They might be able to. I'm not sure what. I'm not sure if if their therapists are receiving training on how to do the specific work around clients that are receiving ketamine and psilocybin. They do see people. I believe that there is a time restriction though, so that you'd have to line up your psychedelic treatment with the availability of the therapist, and they'd also need to have the training.
I guess in terms of like accessibility, those are like sort of you want to say the grassroots levels, sort of entry points to the basic assessments.
Yes.
For addiction, and so it would be great if you lines it up at one, specifically another catchment basin.
Yeah.
At least that's touchable.
It is, and it would also be a great kind of new arm for this to go through if the work that Dr. Tam and his team are doing through UBC, if they've got the numbers and the research to back it up, it might be something that Vancouver Coastal Health looks into for future.
There's like 6 or 7 health units, so it's somehow.
Yeah, with the health unit, with like any of the government programs or like the VCH program specifically that I can speak to, there's always a time constraint though. We always say like a client is limited to this amount of time to like resolve, complicated things. So it gets tricky with those because it's hard to put that.
Discharging, sometimes there's ways around that.
Yes.
Or sometimes there's ways around.
Yes.
Somebody just kind of stay on.
Yes, thanks to the work of very dedicated clinicians.
Can you clarify with the inpatient programming?
Mhm.
We see that people get referred and they get admitted to
Yes.
that treatment.
So they're admitted there and they stay there for approximately 3 weeks, minimally, because that's the 3 weeks is the full course of the program. And yeah, they do stay there. So I believe they where they're staying is a neuropsych program, which I believe is a regional program. That does receive some funding through Vancouver Coastal Health, but the ketamine and the the ketamine program is run in the same area where the ECT program is run out of, and they run they run ECT and ketamine simultaneously. Yeah, if you're familiar with the geography of the space, the unit is just down at the end of the hall, so clients just kind of walk down the hall to the ECT suite, and that's where both of those treatments take place. Is there anything else?
Right. Well, thank you so much, everyone, for joining today. Yeah, big round of applause for Farinah. Thank you so much for your work and presentation and sharing. All right.